A GP Consortia is a group of GPs working together as described in the recent white paper. NHS Cambridgeshire decided to run a pilot for this starting at the beginning of 2010, and we've been working with them since then to set up a group of GPs based in the Huntingdon area. We represent about 80,000 patients with an annual budget of £98 million. We run a central board of clinicians as well as patient representative and represent 9 Huntingdon practices.
I'm a GP at Yaxley Group Practice, but also, perhaps more important in this context, the chair of the Borderline Commissioning Group, which covers 4 practices within NHS Cambridgeshire and with plans for expansion for at least 4 or 5 other practices within NHS Peterborough. I think in the end all GP practices are going to be part of a consortia.
There will be enormous benefits, as I see it, for patients and clinicians by having GPs involved in the heart of the commissioning process. For patients, they can be assured that the NHS is in safe hands. It will be made by people who understand exactly what the issues are for ordinary people in trying to sort out their health when they need it.
We live in a geographical area which is some way away from NHS Cambridgeshire's administrative centres, and a lot of their work revolves around Addenbrooke's and Hinchinbrook, whilst most of our patients access Peterborough for their healthcare services. And we wanted to really be involved in commissioning those sorts of services, and we felt we were much better placed at leading those discussions and also interacting with NHS Peterborough. This whole new scheme we felt would give us some greater influence and probably allow us to have some control over our destiny and the destiny of our patients, more importantly, so they could get better care more appropriate to where they live and so on.
Getting engagement by grassroots GPs is crucial, and one of the enormous advantages we have is that we're also working in the system. I'm a working GP, I know what the pressures are, I understand the tensions between the day-to-day need to see patients as well as the need to step up to this wider role. I hope that by representing both camps we can achieve the strategic aims. We've set out some very detailed plans for the future as part of our change plan submitted to NHS Cambridgeshire at the start of this project. Those centre around moving from the current traditional system of primary and secondary and community care to actually more of an integrated care system. I'm looking forward to patients being able to enjoy a seamless move from community care, contact with their GP, admission to hospital only if they absolutely need it. As part of our initiatives, I anticipate over the next 12 months that far fewer of our patients will need admission to hospital, and if they are needing hospital admission, they will be staying there for less time.
We've got to obviously try and develop some synergies between health and social care, which again has proved really difficult to actually deliver under our current systems. And for us is actually a key area because we work across so many different local authority and PCT boundaries, being in the borderline area that we are. And I think a lot of the other things which we're going to be developing is the new care pathways. I mean, I think the thing that we're probably bringing most of the party is our clinical expertise. And actually, how do we design new pathways which are more efficient and more effective for patients and perhaps more cost effective, and perhaps take them out of the hospital setting. And that, as ever, is always going to be quite a challenging agenda. And I think it's also trying to work out what things which we don't want to do. Because it's clear in view of the management savings that the government wish to achieve with the dismantling of the PCTs, we will not be able to carry out a lot of the functions that the PCTs have historically done. So we're going to have to make some decisions about what we don't do. And that we've only just started thinking about that.
We are reviewed every 3 months. If we're in a stable condition and it isn't something that's likely to change too quickly, it could be 4 or 6 months. or at any time at our request.
The healthcare that I received recently was to have a scan done here at the surgery on my leg, and the two girls that turned up to do it, very, very helpful. They told me what they were going to do, how it was to be done, and when it was over, they told me that I had a slight problem. Straight away, the doctor was there and said, right, we need treatment for that. So you'll need to start on this particular course of treatment, and every 2 weeks I'm monitored, it's logged, and I've got a book where they keep all the records of it, and the medication is adjusted accordingly, and I feel fine.
From day one, from coming here to coming out, was absolutely wonderful. I mean, nobody could have had better treatment. From the surgery, from the surgeons, from the ward staff, and the staff up here, been first class.
I do a lot of caring for my husband because there's not a lot he can do for himself. I think I was finding it, until they got my blood pressure under control, I was finding it very difficult. And also, I wouldn't be able to do it if I didn't have the pain control treatment for my back and arthritic condition. And obviously I can continue doing that for him. And I can continue a social life. I do quite a bit of work for the patients' participation group. I couldn't do that if I didn't receive the treatment and care that I do get.
Well, the treatment I received at the surgery has helped me immensely, because when I came out of Addenbrooke's, I had so many problems following a leg amputation, heart attacks, collapsed lungs, and the treatment that I received here has been really excellent, and they've got me back on track.
Although we both know that you can't cure age and you can't cure things that are worn out or are near the end of their days, but it does help you both to keep feeling well physically, doesn't it?
Yeah. If I get a new pair of legs, I'd be made.
If you think of anything which would be good, which will come out of this process, I think top of the agenda, and the main reason why I'm involved at all, really, way back to why did I want to be a doctor in the first place, is that you really want to put the patient's interests at the forefront of what they need for their particular health problem. And I think putting patients back into the centre of the decision-making process, I think we're probably better placed than PCTs have historically been, and certainly probably better than the secondary care providers have historically been, in trying to get patients' representatives and their thoughts and their families back into the decision-making process, how they want their care delivered, and how the services are going to be set up.
I'm very excited to be involved in the GP Commissioning Consortia scheme. For a number of years now, I've been involved in different pieces of project work, and it's an excellent opportunity for us to bring that together and to start to commission with a clinical focus. It's been quite difficult to innovate historically, but there is a real spirit now of needing to move forward, partly because of the financial situation, but also to make sure that patients get the best experience and get joined up integrated care.